right. Well, good afternoon, everybody. Welcome to the RDAR Center's March Seminar Series event. My name is Blakely Kemp, and I have the pleasure of introducing our speaker today, Dr. Carrie Oser. Dr. Oser is a university research professor in the Department of Behavioral Science in the College of Medicine at the University of Kentucky. She serves as the Associate Director of the Center for Health Equity Transformation and the Substance Use Research Priority Area. As PI, Dr. Oser has been NIH funded for 2 decades and has published over 150 papers on addiction health services, health disparities equity, HIV, social networks, implementation science, and substance use. Today, she will be discussing her work on the role of social networks in substance use treatment and recovery among people involved in rural criminal legal systems. Before we begin, just a quick note, please submit your questions using the Q&A feature. And at the end of Dr. Oser's presentation, we will be sure to address them then. Dr. Oser, thank you so much for joining us today, and I'll turn it over to you.
Thank you so much. I'm pleased to be here today with the RDAR community. And thank you for that kind introduction, Blakely. Again, my name's Carrie Oser. I'm from the University of Kentucky, and most of my research has focused on people who have substance use disorders and are involved in the criminal legal system. And I've worked a lot with rural dwelling individuals. Today, I'm going to be talking about the role of social networks and how they influence the recovery process. So my agenda for today is to talk a bit about what are social networks and why they matter, particularly in rural areas. I'm going to introduce 2 different studies. One is a longitudinal cohort study that we're also using a mixed methods approach, and it's focused on the use of medications for opioid use disorders and looking at social networks' role in the use of those medications while people are incarcerated, as well as during the high-risk reentry period. And then this study has led to a newer study, which is an intervention-focused study. It's mHealth focused using EMI, and also looks at the role of stress in social networks. And then we'll wrap up and save some time for you all to ask me questions. So let's talk about social networks and why they matter, especially in rural areas. So when you all think about social networks, you probably think about social media platforms, Facebook, even the way old MySpace, if you remember MySpace, or the newer platforms, and Instagram and Snapchat. And those are all definitely social networks, but we'll get into a little bit more about what I mean when I'm talking about social networks. I like the definition from Wasserman and Faust, which talks about social networks as a set of actors and the ties among them. So that essentially means that as people, we're social beings and we're connected to other people. We have ties between us. Social networks are both a method and a theory. As a method, they're used as a set of tools for analyzing relational data to look at those ties between people. We can look at the strength of the tie, the type of the connection, and how they influence behavior. These social network data often require special types of data collection platforms. Of course, you can use REDCap or Qualtrics or paper-based surveys, but it's a lot more difficult to collect social network data, and we usually rely on specific types of data collection platforms. Social networks can also be viewed as theoretical approaches. They provide the mechanisms for an array of social patterns and processes. We can look at the interconnectedness between people. We can also use networks to look at social influence when you're talking about substance use in rural areas. Who you're associating with may influence your behavior, your decisions for certain types of treatment approaches, or also your attitudes. Social networks can also be viewed as theoretical approaches in looking at access to resources, not only financial resources, but also opportunities when you think about the strength of weak ties in terms of access to jobs, in terms of access to information. So people's placement in a network may influence the power that they have over others, how they can influence others, as well as constrain their behavior. There are 2 different types of social networks. One that people commonly think of are sociocentric or whole networks, but then there's also egocentric or personal networks. So I'm going to talk briefly about both of these. So in sociocentric or whole networks, those networks focus on a socially or geographically bounded group. And we look at the global structure of that group. The patterns of interaction are usually used to explain group level outcomes like concentration of power or information diffusion. And we are interviewing and collecting data from everyone in that network. We have essentially a roster of all of the names of those network members. So each little square here in this whole network is a person. A perfect example would be a school. These are all, say, students in a school. We could stratify it by gender, where the red nodes are women, the blue nodes are men. We can look at the ties between all of the people in those networks and verify that they're bidirectional. The size of that node or network, if it's bigger, that means that they have more connections to more people. And the goal with whole network data is really to generalize to other whole networks. But what I'm really interested in is egocentric or personal networks, which you see over here on this side. And in egocentric networks, we're focused on the composition, structure, and function of an individual's own network. So we're collecting data from one individual, the ego or participant, asking them about people that they have different types of relationships with, to understand how those patterns of interaction can explain individual level behavior. This can be health outcomes, it can be status, mobility, or status attainment. And again, the cases are at the individual level. And our goal is to our goal is to generalize to other individuals. So why do social networks matter in substance use recovery? Well, networks significantly impact outcomes across the recovery continuum, ranging from people recognizing that they have a problem with substance use to entering treatment retention, as well as aftercare or remission. Social network members offer an array of social supports. They can provide childcare, informational support, monetary resources, and all of this relates to how a person is integrated into society. Rural communities in particular are faced with overcoming structural barriers to accessing recovery resources, including access to large, diverse recovery support networks. Social networks impact recovery. We know that they do improve recovery outcomes, and that social integration and support enhance self-efficacy, which is the belief that a person can achieve his or her goals, achieve their goals, and that social support is associated with increased self-efficacy. And more recently, there's been a focus on people with lived experience being involved in the research and treatment processes through peer support specialists and recovery coaches. So peer support plays a major role in recovery efforts. Within rural areas, social networks also matter. And when we think about social networks in rural communities, they're just less densely populated. So there's fewer people and there's less network turnover and turn in. So less people coming to the rural areas and fewer people leaving. So the available pool of new connections is limited. Rural communities also face elevated rates of substance use disorder alongside well-known barriers to care, like lack of transportation, community stigma, healthcare provider shortages, and less confidentiality, because in rural communities, people often know other people in that community, and so there's concerns about confidentiality when people are navigating healthcare systems. But there's a lot of positive benefits of rural communities. Rural communities have strong kinship ties and generational resilience to structural determinants of poor health. And this creates a lot of partnership possibilities for research and developing network-based interventions for recovery success. So there's one well-known social network study that's focused on rural areas called the SNAP study. But other than the SNAP study, most of the network data for people who use drugs focuses on urban areas. Within the larger network data, we know that rural social networks are typically smaller, more homogeneous, where people look like other people in their networks in terms of their race or their socioeconomic status. And there's a strong emphasis on kinship ties for relationships in rural social networks. One of the things that we're focused on is how technology can work to address gaps or barriers to care. And research shows the promise of virtual interventions that are offered via telehealth platforms can be particularly relevant for rural dwelling individuals who are in recovery. And this has especially been highlighted. The possibilities with telehealth have skyrocketed since the COVID-19 pandemic. So I wanted to give you first this background about what social networks are and what they look like before I got into our first research study. I'm going to be talking about the Geographic Variation in Addiction Treatment Experiences, or GATE study. And you can see our GATE icon here. We're focused on people who are incarcerated and involved in recovery efforts from both rural and urban communities. This is a mixed method study that uses a social ecological framework. And we're interested in looking at multi-level facilitating factors and barriers that predict the use of medication for opioid use disorder while people are incarcerated. And we are particularly interested in the individual characteristics, but also the social network characteristics that influence treatment decisions, as well as structural factors. Most of the research out there focuses on individual characteristics, which can kind of promote a victim blaming ideology. And then we also have a focus on structural factors. But what's often missing is that focus on relationships with other people. So our outcomes in the GATE study are looking at predicting medication for opioid use disorder. And then we're also following up these rural and urban individuals once they're released from carceral settings to look at continuation of treatment as well as adverse outcomes. And this study is supported by NIDA. The GATE study is a longitudinal, prospective, and retrospective observational cohort study of people with opioid use disorder. We've recruited and enrolled 395 people. The eligibility criteria were that people had to meet criteria for opioid use disorder. They had to be treatment seeking, meaning that they had participated in a prison-based treatment program. They didn't necessarily have to complete the treatment program, but they had to at least be enrolled. They could have either chosen to withdraw from the treatment program, or they could have been asked to leave because they weren't compliant with the treatment standards. And then also people had to be meeting with the parole board, serving out within 60 days, because we were following people for a year after their release back into the community. And so we've been able to collect data from 395 people. The baseline survey was broken into two parts. The first part was completed while people were incarcerated, and then part two of the baseline occurred right after people were released from prison. We collected follow-up data at 6 and 12 months post-release. Our goal is to triangulate this longitudinal cohort data with rich qualitative data from key stakeholders in various groups. So we used a census-based sample to conduct qualitative interviews with administrators and clinicians in all of our prison-based substance use treatment programs in Kentucky. We also randomly selected one treatment mentor who had graduated the substance use treatment program inside the prison and was serving as a peer mentor from each of the programs inside the prisons across Kentucky. And then we also conducted qualitative interviews with clinicians working with people who are on community supervision. So these clinicians are based in probation and parole offices. They provide assessments, referral to care, but they don't provide direct clinical services to individuals with substance use disorder. They do help navigate that transition during the reentry period, especially for people who've initiated medications, and help address to ensure that the person has the appropriate level of care. And then finally, we wanted to make sure that people with opioid use disorder, that their voices were heard. And so we sampled 41 people who had opioid use disorder from the longitudinal cohort and conducted qualitative interviews with them. This is stratified by rural and urban, so half of the participants were from rural communities. And then it's also further stratified by people who initiated medication and those who did not initiate medication while they were incarcerated. So you can see our GATE cohort profile here. We started this project at the onset of COVID, which was extremely challenging. We had to change our screening and recruitment protocols at the very beginning, sending screeners to people who were incarcerated. So a lot of the screeners that we got back did not have good detailed information at times about release and contact locator information. Of those, over 1,600, 898 were able to participate. But during the early stages of the study, we got down to 492 people who were consented and completed the first part of the survey. Those drop off there was because people were either not released or they were released, but we didn't have good locator information on them. And then we had 395 participants who completed both parts of the baseline survey. So here's our interviewer team. They're masked up, ready to go inside the institution to do recruitment and baseline surveys. We're really pleased with our retention rates. We think they're quite strong, 84% for 6 months and 86%. And we are just now wrapping up our data collection, and it'll be completed in the next few months. So we wanted to give you a brief snapshot of what GATE participants looked like. We're still working through all of this data. And like I said, our goal is to triangulate the data by looking at the qualitative data in conjunction with the survey data. But you can see here that the average participant is about 39 years old. We enrolled almost 25% who were women. The majority of the sample is white at 81%, which is reflective of the substance use treatment program demographics. It is not representative of the prison population. The majority had high school degree. And you can see that participants also had extensive criminal histories with age of first arrest at 17, an array of lifetime convictions, and about over 4 years incarcerated for the current incarceration. When we look at their substance use experiences, the majority meet criteria for severe opioid use disorder, have a history of injection drug use in the 6 months before incarceration, experiences with overdose, as well as using mutual support groups and substance use treatment back in the community. We asked about the use of medication, the 3 FDA-approved medications for opioid use disorder, and over 1/3 had experience with buprenorphine, whereas fewer individuals had experience being prescribed extended-release naltrexone or methadone. We also asked about willingness to use medication, which was around the midpoint for willingness to use different types of medications for their opioid use disorder. Now, for those familiar with criminal legal system settings, this should not be super surprising, but there was not a lot of uptake or initiation of medication for opioid use disorder. About 15% of the sample had decided to initiate medication while they were incarcerated. And some of the reasons for the low uptake, we asked people in the survey why they chose not to initiate naltrexone. Naltrexone was available for anyone who completed the prison-based treatment program. And about 80% had completed the treatment-based program, and they had to be clinically appropriate as well. And we asked people why they chose not to initiate medications. And you can see here that there was a strong desire for not using medications, which they labeled as abstinence. People said they weren't offered the medication by treatment staff, which could be for those individuals that had not completed the treatment-based program. Buprenorphine was offered on a pilot basis in 3 of the correctional facilities. And now they have become ADA compliant and are offering all 3 types of medications in the institution at intake. So if we look at this by rural versus urban areas, there were no significant differences in terms of the types of medications used. So turning to the network data, Again, we were focused on egocentric networks, social support networks specifically, and we asked each of the participants we asked them 3 name generator questions: who they rely on for support, who they talk to about their substance use recovery, and then we also wanted to get at negative ties, or who makes their recovery more difficult. So when an individual participant names individuals, they usually provide either a nickname or the first name and then the first initial of the last name for network members. And we follow up with those network members in additional surveys, or follow up with the participant about those named network members. The sociograms are displayed here. We use Network Canvas to collect the data, which does display these a visual depiction for the participant of what their network looks like at the end. And participants really like this social network data collection software because it's very user-friendly and intuitive. I'm not displaying rural versus urban networks because there were no significant differences between rural versus urban networks. They did look very similar for people who were incarcerated, but we did find some differences in average networks of male versus females. You can see that the female networks are a bit larger. They're more likely to, this is what a typical female participant's network looks like. They have about 6 network members, 4 family members who are all interconnected. And then they also usually name at least one friend and somebody else who is incarcerated with them, either a clinician or someone who is in the treatment program with them. So we also looked at bivariate differences between rural and urban participants on different aspects of their social networks in terms of the structure, the composition, and the functions that network members provide. So you can see here in table 5 that on average, rural and urban participants are both naming about 4 network members, supportive network members. And that density is coming mostly from family members who are connected to each other. And they're naming about 3 people that they can count on for support, as well as 3 people that they discuss their substance use. And you can name the same network member for different name generator questions. We also asked about how people are related to their network members. And then the majority of named network members were family, over 2/3 for both rural and urban participants. However, urban participants had a larger percentage of their network that were comprised of sex partners. There's very little sponsors or recovery coaches, healthcare professionals, substance use treatment professionals, or peers in their treatment program that are named in rural or urban networks. When we look further at some homophily measures, you can see that there's no significant differences in rural versus urban networks. And the majority of the network is from the same county as the participant. They're not naming a lot of people who are incarcerated with them, but over half of the network has used drugs with ego. We also see that they're comprised of networks that have lower rates of overdose events and injecting drugs, and they don't have a lot of other people who are in their network who are in recovery or remission. It's about 1 person that they're naming, and low rates of people in their network who've used medications. When we look at different types of functions and beliefs by rural versus urban, we do see a few differences. There are some Likert scales where we asked each of the ego participants how frequently they communicate with their network members, how close they are to each of their network members, and the level of trust with each of the network members. Those were on a 1 to 5 Likert scale. And you can see that overall, the frequency of communication and the closeness and the trust is pretty high across the board. We asked about different types of support functions, social support functions. There was a difference with rural networks having a higher percentage who provide emotional support as compared to urban participants' networks. And we also asked about different types of recovery social supports. Rural participants had a higher percentage of their network that listened to their substance use problems and provided support for stopping drug use. Each of the participants was asked how much each of their network members were supportive of their use of naltrexone, buprenorphine, or methadone on a scale of 1 to 5. You can see that there's higher acceptance for both naltrexone and buprenorphine than methadone, but no significant difference across rural versus urban. And so this table displays network variation among people who initiated medication for opioid use disorder versus non-initiators. And there was a mean increased desire to use drugs based upon association with certain alters. This was greater for people who initiated medication, meaning that they may be initiating medication for their opioid use disorder as a protective mechanism. So in addition to all of this quantitative data, this is just a snapshot of baseline at the bivariate level. We're working right now on more advanced models, trying to untangle some of the geographic differences at those multiple levels of influences, as well as combining it with some of our qualitative data. When COVID first onset, we began with our qualitative data. And so I want to share a snapshot of a few different publications that we've pursued related to medications for opioid use disorder. Again, we did a census sample with all the clinicians and administrators, and we asked them about social network influences on their clients' use of medication and how the network members were influencing people's use of medication. We thought that networks would be broader, that they would be naming more people that they were incarcerated with, as well as some friendship networks. But what really emerged from the clinicians' perspectives were those kinship ties and clients' families. And so that's why the paper focused on familial network influences. So 3 themes emerged. The first was that clients' families had a real lack about what medications were, how they worked, what the mechanisms were, and that they were evidence-based and could protect against overdose events. There was also this belief that we've commonly heard that the use of medication is replacing one drug for another, and that it's a continuation of illicit substance use. And there was this widespread stigma across that varied across the type of MOUD, and it was more prominent with agonists and partial agonists than with naltrexone. We also pursued a qualitative paper looking at the community clinicians' perspectives, because the community clinicians were working not only with clients who were on probation and parole, but they were also working with probation and parole officers and judges and the prison-based staff. So we wanted to understand how the criminal legal system influenced the use of medication in the community. So there were a couple of facilitator themes as well as a couple of barrier themes. The facilitator themes, the clinicians talked about how good time credits were an incentive for the use of naltrexone. At the time, good time credits were only available for naltrexone and not for buprenorphine. And they also talked about how staff had positive views towards naltrexone because there was no abuse liability there that they felt. Barriers that emerged were that there were poor interagency collaboration with the client's use of medication. It was challenging for someone to be released. They talked about this in a rural area and specifically, and trying to get them connected to their Medicaid or health insurance provider, and then get an appointment within a month of being released and having their last injection. And that was a challenge for continuing their medication treatment. They also share that there were negative staff attitudes towards buprenorphine and methadone, that judges were saying people could not be on these types of medications, and that probation and parole officers sometimes had negative views about agonists or partial agonists, and even other clinicians, they noted that some clinicians also had negative views towards these medications. We looked at another paper based upon COVID-19's impact on SUD treatment for people on community supervision. And this was stratified by rural versus urban clinicians. The reason we decided to look at this was we heard from the Department of Corrections that there were a lot of silver linings associated with the pandemic, and it produced some changes in how they structured their interactions with their clients and their treatment that they wanted to maintain afterwards. So there were some universal themes that were across geographic regions. Both rural and urban clinicians talked about how telehealth increased modes of communication. All of the clinicians had cell phones, so they were able to text participants or people on supervision, which increased the communication opportunities. They could also, some worked across multiple counties and could call participants instead of just being in their office when they had cell phones, and they could be on the road. But it also had the challenge of creating more paperwork and technological challenges for their clients. In terms of setting up telehealth platforms, we were all learning how to work with Zoom. Some individuals didn't have, email addresses or weren't familiar with technology, so they were trying to help people access treatment resources via technological platforms. How to get paperwork signed was a challenge for them. And so they discussed these issues. They also felt that telehealth required more effort and interagency collaboration, and that it also limited the information they had on their clients. So they were meeting with their clients virtually, and that that virtual communication limited the ability to establish rapport, to look at visual cues, to help determine if people needed higher levels of care. There were two rural themes that emerged. You can see illustrative quotes here. One was that telehealth options removed SUD treatment barriers. And one of the rural clinicians talked about how one of their clients had to pay $50 both ways for a 25-mile ride to their intensive outpatient 3 times a week. So that is, an extra $300 a week, which just is not feasible for people. And being able to interact with their clinician via telehealth and remove that barrier. And then also that they wanted to keep the flexibility with programmatic requirements. So they were able to use journaling and reading literature and other aspects for mutual support groups online that met programmatic requirements. So we're still working through all of this data, but we do have some preliminary things that have emerged. The first is that MOUD is underutilized by people in prison for an array of factors. There's stigma, both by individuals and both at the systemic level. There's also desire for abstinence, or what people call abstinence, or using no medications. There was poor interagency collaboration from the perspective of the clinicians, and then methadone was not available at the time. And what our findings have yielded are unique network-based impacts on people's use of medication for opioid use disorder, that we need to do a better job about educating family networks about the mechanisms for medications for opioid use disorder, the benefits, and how reentry is a high-risk time where people's risk of overdose are elevated, and that medications are evidence-based tactics to help reduce overdose events. We have also emphasized the need to make sure that everybody walking out of a correctional institution has naloxone in their hands at the time of release for this same reason. And this study has also shed light that telehealth and mHealth interventions may be useful tools for promoting recovery for clients in rural areas. And so some of this has led to the next study that I'm going to be talking about, which is the PROMISE study. And PROMISE stands for Promoting Recovery Outcomes with Motivational Interviewing and Social Network Engagement. This is a pilot study. We have internal pilot funding to develop this mHealth intervention. It's an EMI intervention, and we're looking at social network characteristics and stressors experienced by rural people who are in recovery and involved in the criminal legal system. So we chose to focus on people who are at the end of the care continuum, because most interventions focus on getting people into treatment or even on treatment retention. But we see very few interventions that are focused on the aftercare component in rural areas. So we have 3 aims in our pilot PROMISE study. The first is to collect some qualitative data to help develop the intervention manual and also to inform the app development. We've been working with the app developer for the past 9 months on a weekly basis to develop the app, and we're getting ready to launch an open pilot trial to look at the feasibility and acceptability of the PROMISE intervention. And so we're going to use all of this data to write an NIH application if the findings are promising. So in phase 1, we've done key informant interviews with 10 individuals who are from a rural area who have recent involvement with the criminal legal system. Our qualitative interview guide was designed to ask them about the strengths and challenges of what we were proposing for the intervention and to get their suggestions and feedback for improving the intervention. Some of the strengths, they talked about the incentives, the reminder messages that are built in, and confidentiality statements. They also talked about some of the challenges with trustworthiness, if we could have interviewers who are from the community or people who are in recovery doing the data collection or serving as the interventionist, that would be beneficial. And they also talked a bit about hesitancy to name alters or network members. And they mentioned difficulty in maintaining project materials. You can see some illustrative quotes here from some of the challenges. And they had suggestions for bonus incentives, making sure that crisis resources and community resources were available, and that the interventionist was working with non-judgmental approaches when using motivational interviewing. So we've worked closely with all of this feedback. We've also worked separately with the community advisory board as well to develop the intervention. And we have incorporated some of their suggestions, which you'll see in the next few slides. But we have resource guides, we have incorporated bonus incentives, consistent reminders, and so forth. So for the open trial, our goal is to recruit 20 individuals from a recovery community center in a rural rural county in Kentucky. Over the course of 8 weeks, participants are going to monitor stress using self-report measures through the daily survey. And we'll also have Garmin Watch reports, which link to the app. And the daily survey will also inquire about triggers, cravings, substance use, and their social network interactions. There will be 5 virtual sessions with the interventionists, and we'll be collecting data, including REDCap data, as well as social network data with Network Canvas and urine drug screens at 3 different time points: at baseline, at the end of the intervention period, which is 8 weeks out at time 2, and then 12 weeks out at time 3. And our outcomes include acceptability and feasibility. So again, we'll be recruiting these 20 individuals from a rural community center that's been our partner. On other projects, the eligibility criteria are listed here: at least 18 years old, identify as being in recovery for at least 3 months, from a rural county, have criminal legal system history involvement in the past 6 months, meaning they've been arrested, on probation and parole, incarcerated, and that they have to have a smartphone. We understand smartphone may be a barrier, but we feel as though with a small budget, with a pilot study, that we want to start with people having a smartphone, but we'll address that in the larger randomized controlled trial. So in our mobile app, it pairs with the smartwatch, and participants will use the PROMISE mobile app to complete daily surveys, as well as track any triggers or usage events, and they'll have access to a resource page. Their stress levels from the Garmin watch will populate in the mobile application. We have a manualized intervention, and that participants will meet with a trained interventionist. The interventionist will be using motivational interviewing techniques for 5 sessions. Sessions 1 through 4 will be on a weekly basis, and then a booster session at week 8. This is all grounded in helping to build recovery capital for individuals, and participants will develop a recovery change plan during these sessions, explore trigger identification and management, and address any triggers related to networks or their social networks. So it's really trying to make that like this, the network environment and stress, body connection, mind body connection, environment connection. So here are some screenshots of the mobile app. This is the opening screen. Participants are compensated $1 each day for completing the survey. It's tracked here as well as on a chart. We took the feedback about having resources available. So we have coping skills, treatment and recovery resources, and harm reduction and crisis management resources. For coping skills, our team has created several videos on mindfulness meditation, mini yoga, and then an urge surfing exercise, which the interventionist goes over all of these techniques, but they're also videos that are available on YouTube that the participant can access from their phone and their app at any time. There's a diary function where people can track their triggers or usage events, as well as a calendar entry function, which you see here in this last screen, that tracks each of their daily surveys, any triggers or usage events that they enter. And then the interventionist can also add things to the participant's calendar, like their next intervention session. For the daily survey, the person receives a notification. They get to set the time that they would like to receive the notification, and there's an additional reminder sent out later in the day. And it asks the participants to answer questions about their day yesterday and their current day. So first it asks to self-rate their stress for the current day, and then it pulls in the information from their Garmin watch about their stress level for yesterday. It's on a scale of 0 to 100, so it's very interpretable, and we provide both the average and the max score. It asks the participants to answer why they think they had this level of stress. But for participants who don't wear their watch the previous day, it'll say undefined. And then the question will say, what made it difficult for you to wear your watch? The interventionist is able to access all of this information, so they can use this information and help address any challenges that participants may have, and to help build that recovery capital to sustain their recovery journey. The morning survey asks about different types of triggers that the participant experienced, and they're tied to recovery capital domains. And then we pre-populate from the baseline social network survey their named network members. So this participant named Alan, Ellie, and Tim at the baseline as people who were involved and provided them support, or who they talked to about their substance use problems. And the question asked, based upon the most impactful trigger from yesterday, who was involved. You can select any of those network members or none of them, or you can add new network members on a daily basis. We also ask about craving, and then substances use and injection drug use behaviors. So we are really excited. We're getting ready to launch this open trial. And we believe that this will be extremely beneficial to people in rural communities because of the M-Health focus. It addresses some of the transportation barriers, and it'll help engage and build support networks for people who are in recovery, and help reduce disparities among populations with criminal legal system involvement who are rural dwelling. So that is all I have for today. I wanted to acknowledge all of our participants who shared their stories, our community and correctional carceral partners. We've also worked with the community advisory board called the Survivors Union of the Bluegrass in developing these research studies to make sure that they are representative of people with lived experience. We have a great research team, including co-investigators, and are grateful for our sponsors.